Start with the next session, that is the healthcare category session. Our panelists for this session remain the same. Mr. Shailesh Godikar, Head Corporate Quality Assurance Marico, Dr. Mini Panikar, Founder Sahbhav, Mr. Kunjumon, General Manager Product Dispatches Bharat Petroleum Corporation Limited, and Mr. C.A. Jagdish Shenoy, Senior Vice President, Edelweiss Limited. Now I invite our presenters to please come and take their seats on the dais. Dr. Sanjeev K. Singh, Medical Superintendent, Amrita Institute of Medical Science and Research Center, Kochi. Dr. Snehal Majumdar, Director, Blood Bank, Ruby Hall Clinic, Pune. Mr. Saji Matthew, COO, Baby Memorial Hospital, Kozhikode. Mr. Vimal Megavarnan, Manager, GVK EMRI, Sikandarabad. And Dr. S. Rajashekaran, Director, Ganga Medical Center and Hospitals, Coimbatore. I invite Dr. Singh from Amrita Institute of Medical Science to please come and deliver his presentation.
Good morning, ladies and gentlemen. Yeah. I'm Dr. Zubair Mohammed. Dr. Sanjeev Singh couldn't make it today. On behalf of Team Amrita and Dr. Sanjeev Singh, I would like to thank the organizers for giving us the opportunity to present our work on antibiotic stewardship program. The antimicrobials that we use now were mainly discovered, most of them, in the last century. Overuse of antibiotics has led to resistance among the microbes, leading to treatment failure, increased cost of care, morbidity, and mortality. Also, there aren't that many antibiotics in the pipeline to help us in the near future. The cause of antimicrobial resistance include, among others, inappropriate antibiotic prescription, over-the-counter prescription of antibiotics, use of antibiotics in livestock and farming, and also inadequate antibiotic refuse management. Antibiotic stewardship program can be a solution to many of these problems. We started our antibiotic stewardship program at Amrita Hospital in the early 2016. We decided to review the appropriateness of antibiotic prescription based on the 5 R's, which is the right drug for the right indication with the right dose, the right frequency, and the right duration. We found that over the years since we have instituted the antimicrobial stewardship program, the appropriateness of prescription has improved from 56% to close to 80% over the 3 years. The antibiotic consumption as defined by the defined daily dose has decreased to the extent that there's about a 60% decrease in the use of high-end antibiotics and almost 80% reduction in the use of some of the antifungals. There's been a decrease in the length of stay from 7.9 days to 5.9 days, which is almost a 25% decrease, and a decrease in mortality per 100 bed days from 7.8 to 2.8, which is around 65% decrease in mortality of patients. The graph on the top shows the monthly mean antibiotic consumption, with the y-axis that shows amount in lakhs of rupees. It's clearly evident in the graph that there's been a consistent and steady decrease in the monthly mean antibiotic consumption from 2015, which is starting or before starting the antibiotic stewardship program, and towards the end of 2018 you see a steady decline. It amounts to the decrease in antibiotic consumption amounts to a cost benefit of rupees 1.2 crore, and because most of our patients pay out of their pocket, this actually is a cost benefit to these patients. There is also an indirect cost benefit in the sense there's a decreased length of stay. The bystander costs are decreased, as well as the lost productive man hours. The hospital benefits in the sense that there is reduced bed pressures because people tend to get turnover faster, plus we can admit more patients, and there is less waiting time for our patients. We took a step forward and included the Amrita technologies and incorporated the clinical decision support systems to help the clinicians make the right prescription of antibiotics, because we've got an integrated Amrita information system for prescription. We improved our diagnostic capabilities using rapid diagnostics and point of care equipments with the intent of acting fast and acting hard. We also developed an in-house Amrita mobile app for appropriate prescription, and also there was an e-prescription module that was incorporated in the Amrita information systems. We expanded our work in collaboration with the government of Kerala, and we were instrumental in designing and implementing the strategic state antimicrobial resistant containment action plan. We were involved in training over 100 trainers regarding the appropriate use of antibiotics and infection control policies. And we lobbied with the government of Kerala and the Kerala University of Health Sciences to incorporate antibiotic stewardship in the undergraduate and the postgraduate curriculum. Now, this shows how we actually went through the process of implementing the antibiotic stewardship program. It is a busy slide. Please allow me to go through it. We followed the non-obedience approach of structure, process, and outcome. So as mentioned earlier, it was initially in January 2016 that the antibiotic stewardship team was implemented, which included a physician, an intensivist, a microbiologist, and an administrative champion. Over a period of time, we incorporated more clinical pharmacists who actually drive the program, and the role of the clinical pharmacist will be explained in detail later. We included, although we started as an antibiotic stewardship program, we included with time antimicrobial stewardship, antifungal stewardship, also instituted an infectious disease team, apologies, and as the workload increases, we increased our capacity and the capability by appointing more clinical pharmacists and including more clinicians in our work. As far as the process are concerned, when we started off, we started reviewing the use of 3 high-end antibiotics initially, and over a period of time, we increased that to include 17 antibiotics. Along with that use of antibiotics, we included multiple processes in which where we can improve the surgical pathways. We included the use of drug levels in the monitoring of drug levels in the blood. We instituted care bundles. We instituted, along with national and international faculties and state collaborators, we had our ventilator-associated pneumonia protocol, prevention protocols, and along with the continuing training and development, we increased the capability of the nurses as well as the rest of the team. What we also did in the meantime was institute an infectious disease team, which along with reviewing the daily patients at the bedside, improved the capabilities of Amrita as a team by improving the stewardship from just antibiotics to what you call laboratory diagnostics, empowering the nurses, along with collaborating and empowering them. These are some of the stakeholders along with we collaborate, which include organization both within the country and outside the country, and along with them, we have published our results in various international journals. It is based on these structure and processes that we were able to, as mentioned earlier, improve or decrease the use of antibiotics by 2/3 and antifungals by about 80%, improve the length of stay, decrease the length of stay, and improve the mortality, and at the same time improve the compliance with the antibiotic stewardship program. This is the website that we maintain where most of our activities are logged in, and this is done in collaboration with the government of Kerala. You're welcome to view it, and please post in your views. As far as the monitoring of the best practice are concerned, now what do we actually do on a day-to-day basis? This is where the role of the clinical pharmacist is instrumental. They review the use of antibiotics within 24 hours of admission, within 24 hours of prescription, and go through the case notes. This antibiotic prescriptions is reviewed with the antimicrobial stewardship team, who actually looks at and gives appropriate recommendations. When appropriate, they will be discussed with the appropriate team. The good practice are congratulated by emails as well as the hospital newsletters. Whenever required, we organize and hold a multidisciplinary team where we review our pathways and try to improve the processes within the hospital, and that can include both clinical and non-clinical teams. The antibiotic stewardship team meets on a monthly basis and reviews the results of the last few months, and we make plans for the coming months as well. Over the next few months, we plan to lead the training of almost 50,000 physicians across the state in collaboration with the government of Kerala. With that, I thank you for your patient listening.
Our apologies, that was Dr. Zubair Mohammed, consultant from Amrita Institute. Now I call upon Dr. Sneha Majumdar from Ruby Hall Clinic to please give her presentation.
Of making quality happen, the delegates on the stage and delegates off the stage. Now, it is rightly said, Dravya Danam Param Danam, Annanadam Tatodikam, Tatasreshta Raktadanam. My entire department of transfusion medicine functions on charity. Only if we have voluntary blood donors can we give the blood to the patients. So we are, as a blood bank, only a bridge between the donor and the patient, but we carry a very big responsibility that we have to do it correctly, we have to do it safely, only then we can benefit the patients. Now to Amrita Institute's 3 rights, I am going to add Ruby Hall's 6 rights. Blood transfusion has to be done in a right component transfusion, I would rather say, because we can now segregate the blood into components. We cannot still manufacture blood, it has to come from the society. But we can segregate it into components, right component to the right patient at the right time, and the vital part is doing it right the first time. There is no place for sorry in my department. Now, the hemovigilance program of Ruby Hall has ensured risk mitigation and business continuity management because we are able to monitor all the important steps in the transfusion, right from the time the bag is issued to the patient till it is transfused into the patient, and even after that, because we have to watch the patient for some time even after transfusion. We have identified all our weaker areas because of this program. So, kachi kadi kaun, kachi kadi kahan, we have been able to recognize. And we have directed all our efforts, all our resources into overcoming them, as you will see in the subsequent slides. Now, risk mitigation by limitation strategy. We introduced this blood transfusion checklist folder way back in 2013 itself. So this is a folder. Judges, if you see, it is slightly thicker. So this folder is supposed to be a file for transfusion inside the patient's medical file. And you know, we always say you have to correctly relate the blood unit to the patient. But how to do it, who will do it, when it is to be done, it is really not clear, the exact SOPs. So this folder has made it all very easy. The blood transfusion, I have to run you through so you understand what I'm saying. The blood transfusion starts with the consultant writing the request for component in the patient's file. The second important step is patient's informed consent. At this point, this folder is introduced, and the first document to go in this folder is the consent. Then the requisition form and sample comes to the blood bank. We keep the bag ready. When the patient needs blood, an important document, the issue note is sent to the blood bank. Then the blood bank issues the required component in required numbers with a color-coded label. These are universal color codings as per the blood group. The cross-match and issue report is given, and from here on, the important procedure starts. A team of a doctor and a staff nurse is supposed to take the blood bag with the label, the cross-match and issue report, and most importantly, this transfusion folder inside the patient's file to the patient's bedside. Independently, both of them are supposed to relate the bag to the patient based on the checklist. So it's very easy, nothing can be missed. All the important steps are to be recorded on the folder. All the important documents go inside the folder. At the end of transfusion, the label is supposed to be transferred from the bag to the folder, and the feedback comes to the blood bank. Isn't the folder fantastic? We had the feeling of deja vu. We have done it all. We trained our staff. We introduced the folder. Now, nothing can go wrong in transfusions. Alas, the happiness was actually short-lived. Our audits revealed that the staff was aware of everything, still shortcuts were being taken. Usually in critical areas, the staff is very confident. Also, they have a lot of work pressure. So the sister took the possession of the blood bag, not all the times, sometimes. She went to the patient, started the transfusions. As and when she got the time, she completed the folder. That's the mandatory requirement by NABH. Also, the auditors come, they pounce on them, so the folder has to be complete. Sometimes, the auditors caught them when the folder was incomplete. The stickers were missing. The reports were there in the patient's file, but not in the folder. We had these problems. Therefore, risk mitigation by transference strategy had to be implemented. Thus was born our Hemovigilance Committee of Ruby Hall. You see, all the important management people are a part of the committee, and we trained our medical coordinators and nursing supervisors to be the auditors. We took a lot of precaution. They will not audit their own section. These are surprise audits. The auditors sometimes go with the bag, sometimes after the transfusion has started, sometimes they are retrospective audits. We started with 1% audits in 2016, increased it to 2% in 2018, and very soon we'll have more samples. These are very transparent audits because we have an audit form. So all the points are covered, nothing is missed, non-conformances are recorded here, the auditor and the auditee signs it. It is brought to my notice, the director blood bank, brought to the notice of the medical director, the nursing director, quality is involved, quality assurance department. Most important, we involve the consultant, the anesthesia consultant if that's the case, or the entire team of anesthesia. The corrective action is taken in real time because the auditors are trained. More corrective action, if required, is taken. Preventive action is also recorded here. All forms are monthly monitored, and we have quarterly Hemovigilance Committee meetings. The results are here to see. Aren't they fantastic? 84% compliance in 2016, increased to 96% in 2018. Fortunately, in last 2 months, I have not had a single non-compliance. These are the same points in the audit checklist. It's very obvious. I had problem with my consents for transfusion. Now my hospital has 9 accreditations under its belt. So none of the transfusions actually happened without consent. But this legal document was incomplete. How? Date and time was missing. Date or time was missing. Signature of witness was missing somewhere. Thumb impression of an illiterate patient taken on English side. Will it stand in the court of law? Biggest problem was next of kin giving consent for an adult conscious oriented patient. The patient could decide what he could eat, but transfusion requirements were decided by the relatives. The incompleteness of the folder I already said. We had trainings for that. So far as the consent is concerned, our medical director went to the length of getting 2 high court these lawyers to deliver a couple of lectures on consent. We had training of our sisters and doctors. Moreover, what we had is special audits only for consents, and the results are here to see. The secret of the missing labels, I told you some stickers were missing in the folder. The reports, of course, they were scattered. We could get them in the folder with training. But what about the secret of missing labels? Only because of the hemovigilance audit, we realized that while transferring the label from the bag to the folder, it was getting torn sometimes because it becomes soggy. You take it from the refrigerator, it becomes moist. So we made waterproof labels. The problem was solved. We don't encourage pre-medication in my institute. But there are certain situations, diagnosis where pre-medication is a must. So there have been a few cases of transfusion reaction. The pre-medication being used, but we found that they were justified to the disease. So what hemovigilance has done for us? Now we are getting 100% feedbacks for every unit transfused. So if there's a reaction, we know it. If the bag is wasted, we can do the root cause analysis. Uneventful transfusions, of course, we know. Look at the wastage. From 0.1%, I agree, it increased to 0.5%. But there could be some underreporting in 2016. The 2017 analysis showed that wastage was in operation theatre more for the major surgeries, heart and liver transplant. Now, in my institute, we have cadaver transplants. So they happen at night. Discussion with anesthetists revealed that there was jittery blood will not reach on time. We gave them mobile refrigerator, data logger. We employed a shuttle boy between the blood bank and the OT only for this logistics, and see the results. Now I'm very sure not even a single transfusion reaction is missed. Delay in starting transfusion. From 54 we brought it to 7. This is because now patient has fever, patient's vein cannot be found, then patient refused transfusion. All these reasons we have done away with trainings. Involving the consultants and involving the anesthesia team, strong support of the management has been the success of this program. Initially there were more meetings because policy decisions have to be taken. We have amended some of our policies and procedures. Later on, the trainings increased. Now, transfusion protocol is a part of every continuous medical and nursing education, induction for new doctors, induction program for the new staff nurses, and of course, these are the results. I think we have actually managed to streamline our practices, and like standing here also, I'm sure that the protocols are being followed. So that's the confidence I have, because every team member, every person in this entire chain is doing their work with dedication. Thank you. Now these are the words of our own Lullaji. Innovative concepts need not be complex, they rather address simplicity. So that's my hemovigilance program of Ruby All for all of you. Thank you.
Thank you, Dr. Mujumdar. Now I invite Mr. Matthew from Baby Memorial Hospital to please come and give his presentation.
Good morning, everyone. Myself, Saji Matthew. Greetings from Baby Memorial Hospital in Calicut, Kerala. I'm here to share an interesting story with you, a story of transformation, how we use digital technology to transform the way we do transport in hospital setting. It is a story about how we empowered our transport crew members who were otherwise just porter in the hospital. Now they are smart transport crew members. It's a story about how we co-created a digital solution, how we mentored a startup firm. Now they are given a launch pad, and now they are taken to the market for selling their solution. It's about how we implemented a best practice in our hospital, and thereby we improved our productivity and also provided a better care for our patients and make it a delightful experience for the nurses and the clinicians who are involved in transporting, or they are the beneficiaries of this end product to the solution that we innovated. Okay, it's a impactful transformation story on the development of the best practice. Not long ago, this was our practice. Whenever a patient needs to be transported from one location to the other for a therapeutic or for an investigative service, the nurse or a technician will make a call. Somebody in the control room will pick up the phone. They send a person. He will do the transport job. Then he return empty-handed back to the location. So this is in this process. Okay, when we have peak load, okay, there were communication errors, and we were not able to meet the acceptable level of services for patient transport. And in the hospitals, these people are used for patient transport and material or document transport. So it was a challenge for us. And our stakeholders, the patients, the caregivers, that's the clinicians and the nurses, and the managers had the challenge, how we take a solution. So we looked around, okay. So in the passenger transport segment, we have Ola and Uber. They use digital technology to disrupt the way we do the transport, and we were able to very cost-effective solution in transport. So we thought about using similar kind of technology. We looked around. There are commercial solutions available which are costly. So rather than going for a commercial, so we try to innovate with some of the young talents through a startup firm. So we harness technology. So that's the real-time location tracking system. So we wanted to empower people who are otherwise just the porters into smart workers, because they had a concern whether the technology is going to replace their job. No, we told them, I stood before them and give the guarantee that no, you will be converted, you will be transported to smart workers, and those who are freed up from this job, we will upskill you for enhanced other jobs. So that is what happened. So we came up with using the wireless technology. So in the hospital, it is completely through a wireless network. We use the access points of the network, and in the telecom segment, we have triangulation principle to locate. So same kind of a technology being used in terms of identifying. So the way it works is the nurse or the technician submit a request for a transport. So it gets logged into the server. The server will send the request through a network of access points to locate who is the nearby porter. So he get a notification. If a person is not available, it waits for a minute. Then it sends one level up, down. If not, people are not available to pick up, it broadcasts to the entire team and they get the notification. And we use a similar technology in the hospital. There are a lot of portable equipment which are vital in providing the service. So similar kind of a technology. So we attach the the BLE tags to that one. The BLE tag will transmit the identification of the equipment, and which we capture through the mobile application. That is also similarly get logged. Now we are able to locate real time. How it works? Okay, there was, as I told, there was a lot of apprehension whether the technology is going to, replace some of the workers. No, right from this is the chairman and managing director of the hospital. So we did a launch event. We educated the people. We told them, no, you are not going to lose their job. You will be made smart workers, and some of you who will be freed, will be enhanced, upskilled to do a better job in the hospital. Okay, there is a real-time monitoring which is happening. So when they put a request, the nursing friend or the people who are putting the request, they can see how many requests and what is the progress, who are the nearby people available. If there is a future scheduled request also, what is going to come to my place. Okay, on the mobile software, they get a notification. That's the transport crew members. They accept. So then they move to the place and they transport, and at end they complete the job. And there is also a provision created. Both the parties can give a performance rating. So that is to describe their experience. Then there is an provision for effective communication during that between the nurse and the porter if they wanted to chat or communicate if anything extra things need to be done. That is also taken care. And in terms of the monitoring, so it's okay, such a technology solution, what benefit it is going to. So within the solution itself, we created the monitoring. So real-time basis, we are now able to monitor how many requests, and on a time scale, like 24-hour real-time basis, what is the kind of demand. Accordingly, we'll be able to arrange the number of transport crew members. And moreover, we are able to see where these people are, whether they are working, they are idle, they are engaged, or even out of the premises. So all those monitoring is there. And rather than using this as a tool to scare them, we use this as a tool to motivate them, saying whoever is going to do a better performance on time delivery, they'll be rewarded for that one, and that we have been continuing. And we built advanced analytical capabilities, as you could see, in terms of which location is having the maximum number, where is the transport. Accordingly, when they are free, so they will be deployed at the location. So we can real-time monitor the demand and supply. So accordingly, we can adjust, and we are building a predictive model also for future requirements. And also on a particular person, we can see their productivity on a Gantt chart, or whether they are free, how many they can do it in parallel. It's not, when it comes to a lab or a file transport, they can do multiple requests at a time, so that way we are able to batch it and then have a better productivity. So the result, in the last 7 months of implementations, we handled 1.15 lakhs of requests through the platform, and the waiting time, we were able to reduce it from 30 minutes to 15. In the past, we didn't have any proper measurement. Now we could see what is the turnaround or the waiting time. And we are able to free up our nursing colleagues who are otherwise supposed to do patient care. In the past, they were just making a call and following up on a transport request. And so that is increased focus on patient care, patching of the request, so error-free communication. The transport crew members, they are doing more value-added work, and their return trips are now, okay, they are able to find out a return. On the return, they are able to carry out a transport that boosts the morale of the people, and we are able to track the portable equipment that improve the patient satisfaction. So we have access to real-time data. So why we call it as a best practice? It's an implementation of a lean management principle. There is social impact in terms of empowering and upskilling the people involved, co-creation with a startup firm, low-cost innovation, and thereby we are able to save in the capital outflow. And also this technology can be replicated in any setting, in a multi-story mall or in a hospital. And already the story was published by NASCOM for the successful implementation of digital technology and how do we interrupt. And the Quality Council of India in the last year, October, when they celebrated the Quality Month, we are given one of the best case in implementation. So we continue our innovations, and we are doing multiple innovations and disrupt the way we render our service. That's for a better tomorrow and for the betterment of the mankind. And our saga of journey, that is our vision, is to provide affordable, accessible, quality care to all the people. Thank you. Jai Hind.
Thank you, Mr. Matthew. Now I invite Mr. Megavarnan from GVK EMRI to please come and present his best practice.
Should I start? Good morning. I am Vimal Megavarnan, Advanced Clinical Educator working with GVK Emergency Management and Research Institute. I'm here to share our experience on Emergency Care Center, the best practice, the right place for the critically ill patient to be stabilized on the way to tertiary care center. GVK Emergency Management and Research Institute is a private not-for-profit organization. We closely work with state governments. We operate more than 10,000 ambulances across the country. We cover 15 states and union territories. We provide global standard of care with the low-cost technology at the cost of rupees 1 rupee per citizen per month. Our operation, we serve one emergency every 4 seconds and save 2 lives every 2 minutes. 1 life every 2 minutes. This is what our volume of service is. We as a cricket-loving nation, our call volume is very, very high. GVK EMRI has got a vision of saving 1 million lives every year. We as advanced paramedic, we understand that if you want to save 1 million lives in a year, we have to service at least 30 million emergencies in a day. And every ambulance has got a 4-wheel. Our organization also has got a 4-wheel which runs on leadership, innovation, technology, last but not the least, research and training. Okay, so why do we need this emergency care center in between ambulance and the tertiary care hospital? Is that, unfortunately, India is the #1 country to lose lives on the road. And India is the diabetic capital of the world, and Hyderabad is the diabetic capital of India. So there are many people who has cardiovascular, cerebrovascular emergencies. This road traffic accident is the burden to our country. Every 1 minute there is an accident, and every 4th minute 1 person died due to road traffic accident. And for 1 fatality there is 20 major injuries and 50 minor injuries. With this number, with this background, only one thing that can save lives which are being lost on the way to the hospital is that just to stabilizing airway, breathing and circulation. So as per our experience, 30% of the patients are critically ill or injured, and those who are being transported to the tertiary care hospital. These patients require this advanced life support care. Okay, what is happening? We have limitation in our ambulance. One paramedic, he has only 2 hands, 10 fingers, hardly could do nothing if the patient becomes critical from the site of an emergency to tertiary care center. What happens? The availability of specialists in the rural area is very, very difficult. So in Chennai, for example, we have established this emergency care center. From my village, I'm 70 kilometers away from Chennai. Till today, my first cardiologist is away from 70 kilometers and my first neurosurgeon is available in 70 kilometers. So people who suffer chest pain and head injury, 70 kilometers we have to travel all the way. Okay? So what is the solution for this? If the patient has prolonged duration of transport, if the patient becomes sick, he has to be stabilized at one point of time so that the mortality and morbidity can be saved. For that, the solution is emergency care center or emergency stabilization center. With the government of Tamil Nadu and government of Goa, we have established these centers. So caller calls 108 and this paramedic prepares everything and goes to scene and provide on-scene care and en route care if the patient becomes sick, and he informed this so-and-so patient is sick, I'm going to bring this patient to your emergency care center. So this emergency care center, people stabilize the patient, and the role of emergency care center is to increase the window of opportunity to save the particular life. So what did we deploy is that we have identified the scope of practice, identified skills that can be performed in the emergency care center, and we have recruited the people, trained them, we have designed a curriculum, and then we have imparted the training to this particular doctors and advanced paramedics. So this is the life savior connect in between from the location of an emergency to the tertiary care center. So this is the interior part of the emergency care center. The role and mission of the emergency care center is to increase the window of opportunity to save individuals' lives which are being lost in the ambulance.
வணக்கம், இது தமிழக அரசின் 24 மணி நேர அவசர சிகிச்சை மையம். இங்கே மெடிக்கல் எமர்ஜென்சிஸ் அண்ட் ட்ராமா எமர்ஜென்சிஸ் 60 நிமிஷத்துக்கு மேலே ஹாஸ்பிட்டல் ரீச் ஆகிற சுச்சுவேஷன் இருக்கிற ஏரியாக்கள்லாம் இந்த சென்டர் நடத்துகிறோம். ஆம்புலன்ஸ்லையோ இல்லை வாக்கின் பேஷண்ட்ஸ் இங்கே ஸ்டெபிலைஸ் பண்ணிவிட்டு இங்கேருந்து ட்ரெஷரி கேர் சென்டருக்கு நம்ம ட்ரான்ஸ்ஃபர் பண்ணுறோம். இதுதான் ட்ரையேஜ் ஏரியா. ஃபஸ்ட்டு இங்கே தான் பேஷண்ட் ரிசீவ் பண்ணுவோம். ரிசீவ் பண்ணிவிட்டு கேட்டகரைஸ் பண்ணுவோம், ரெட்டா எல்லோவா க்ரீனா அப்படின்னு. ரெட் மீன்ஸ் இமீடியட் இன்டர்வென்ஷன், எல்லோ வந்து டிலேட் இன்டர்வென்ஷன், அண்ட் க்ரீன் இஸ் அன் ஆம்புலன்டரி பேஷண்ட். சென்டரில் 24 hours டாக்டர்ஸ் அண்ட் பேராமெடிக்ஸ் அவைலபிளாக இருக்காங்க. We have emergency care medicines. We have instruments like multipara monitor, defibrillator, and ventilator to stabilize the patient and to transfer the patient safely to the critical care. Once after triaging, the dead patient who are critically ill or unstable, who needs immediate intervention, will be transferred to the resuscitation bay, where they will be resuscitated and they will be transferred to the LO bay. In the LO bay, they will be monitored till the arrival of ambulance. Once the ambulance has arrived, the patient will be transferred to the tertiary care hospital. In the green bay, the patient who doesn't need preference will be managed care and will be sent home. We have a minor procedure table and we will do suturing and plinting for needed patients. With these facilities, the emergency care center can effectively stabilize cardiopulmonary arrest, myocardial infarction, stroke, head injury, body trauma and poisoning within the golden hour, and thereby it can increase the chance of survival and reduce the morbidity and mortality.
So that talks about the facilities that what we have in emergency care center, and then procedures that can be performed, including intratracheal intubation, ventilator support, and cardioversion, defibrillation. Whatever we name it for resuscitation and stabilization, it is available in the emergency care center. And there are doctors and advanced paramedic and as well as emergency medical technicians basics work in this center. So monitoring, we have benchmarked the National Institute of Clinical Excellence, and we monitored through adherence to treatment protocol, adherence to equipment maintenance, adherence to aseptic technique, infection control, including the duration of stay in the ECC. What is that we have achieved through this chrome pad? So far, we have served more than 10,000 emergencies in this, and it includes almost 60% of the patients are medical, and 30% of them are trauma, and rest are environmental. So 60% of the critical cases were brought to the emergency department, out of which 76% of the lives were saved, and people who went to cardiac arrest, 5 of them has got their return of spontaneous circulation. So this is one of the best benchmark in resuscitation in our country. The challenges, we have many challenges including scene safety. In case of multi-casualty incident, there are many patients are brought to the center where this center has only a capacity of holding 4 patients at once. And there is also a challenge for the in coordination with the government hospitals. So our recommendation is every sub-district hospital which has 40 to 60 kilometer transport duration for tertiary care center should have this emergency care center for stabilization. And there should be specially trained people in emergency care center. And this is the condition of Mumbai today. So Mumbai is the number of road traffic, Mumbai is leading in road traffic accidents compared to Delhi. And these are the places where this more number of accident occurs in the Mumbai, and 57% of them are pedestrians. They do not hold any vehicles. Still they are injured. So we strongly believe that the Mumbai city should also have to have this kind of emergency care centers. So why is it the best practice? All people who are about to die are being stabilized, and Tamil Nadu Health Project and as well as Madras Medical College has given a certificate of appreciation to this project. Thank you. Jai Hind.
Thank you, Mr. Meghavarnan. Now I invite Dr. Raj Shekharan from Ganga Medical Center and Hospitals, Coimbatore, to please come and deliver his presentation.
Good morning. I bring greetings to you from Ganga Hospital, Coimbatore. And I would like to present here a novel method of intervention that we bought that produced a disruptive improvement and quality of life in a section of the society that has been forgotten, not only by the society but also by the medical fraternity. These are people who have legs but who cannot walk, mainly because of the spinal cord injury that has occurred either due to road traffic accidents or due to industrial place work. And in a minute, their life changes. A person who was the breadwinner and leader of the family in the morning has his spinal cord injured and then becomes paralyzed and then becomes the most dependent person on his family. And everything in his life then changes. Now, this was something that was treated as an ailment not to be treated, and by the American Journal of Trauma as the worst of all survivable trauma. Because these people are from socio-economic and breadwinners, and then they become paralyzed. They not only paralyze themselves, but they paralyze the whole family. Because the wife now cannot go to work, the children have to stay back at home and then look after the paralyzed person. And they go through a series of complications of pulmonary infections and urinary tract infection, and one of them actually finishes them off earlier. Now we talk of many quality indicators, but the most important of them are mortality, infection, pressure sores, depression, and mental health, divorce rates, and even suicide. Now if you look at the rate of what these people undergo, you will know that these are worse than cancer itself. Now why is this so? It is because that the treatment in our country and in many of the developing countries and even somewhere in the West, it was fragmented and incomplete. People looked after at one particular part of ambulance service. Somebody looked at surgery. Somebody looked at rehabilitation. Somebody looked at occupational therapy. And somebody looked at social integration. But they were not integrated together. And many times the patient skipped some of these. And that's why they died very early. Now our aim of this novel method was, can we give them a life without disability? And the novel issue that we made was an end-to-end care from the site of accident, transport, hospital treatment, surgery, rehabilitation, occupational therapy, and social integration. Not segmented, but all running parallelly and simultaneously at one single point of center. And can we also look at their integration beyond the institution and go to their homes and look after them? And in a country like ours, can we make it affordable and sustained? And these were the main challenges for us. Now we integrated the two big centers of the largest spinal surgery center in the country and also the rehabilitation center, and started rehabilitation even when they were in the surgical unit. And right from the surgery, they were then shifted to the physiotherapy center, which was highly specialized, which had 5,000 square feet area just earmarked for spinal cord injured patients. Having many people do at the same time improved their morality. They also have a lot of motivation when they see people like them who were paralyzed before, but after 8 to 9 weeks are now able to be mobilized. We, with the integration of the society, had the best equipments possible to get them motivated and put a lot of scientific input into them and made them faster. Orthotics and prosthetics are very important for them. But when you give a wrong wheelchair, it gives them a pressure sore. If you don't give them the right orthotics, it makes them more crippled. So we established a state-of-the-art orthotics and prosthetic center also. Now, rather than having a vocational service later, as they were getting rehabilitated, we integrated vocational training into them also. So these people had a hope, oh, I could do something when I go back home. And we made them tailors or artists or painters, or even started a small printing press over there where they could sit and do a large part of the printing work over. So their motivation was highly improved, and we could also train them in many other jobs which were possible. Here you can see one of the spinal cord injured patients who had made a very big, very good art, presenting it to Professor D.R. Karthikeyan. And we looked at their mental well-being also. Not just their mental well-being, but the family's well-being also. We brought together the spinal cord injured patient forums, made all of them come together, discuss their happiness and their woes and their problems and how they got well about all. We organized in the evenings group therapy for them. We made them a big team for participating in our Prime Minister Swachh Bharat. They went to the railway station, they went to the bus stands, and they participated in that. And we conducted many competitions for them. Competitions not only for them, but also their family members. So they all became an integrated group. And this was done in the evening times when they used to get depressed. And we also had a state-of-the-art basketball court. So from morning to night, they were integrated into rehabilitation, into occupational therapy, into their social integration, and into their mental well-being. And this was, again, the biggest challenge was to make it affordable. We provided a 2-month inpatient therapy, relevant orthotics, an imported wheelchair, occupational and social rehabilitation, worth rupees 4.5 lakhs for each patient at only the cost of 60,000. And 60% of our people were even given this free because we were able to get a social integration. All the charitable people and the organizations in our community, we integrated them where they subsidized it. So in the last 5 years, we have been able to give a cost subsidy of 3.36 crores to these people by all these charitable people. So what has this achieved? You will see that the results have been very, very disruptive. In all these important outcomes, mortality, suicide rate, severe depression, pressure sore, respiratory tract infection, and early readmissions, you can see we have produced a massive improvement over here. Just going by point to point. Mortality at 1 year was 27.2% in paraplegics. That means people who were paralyzed below the waist. And in quadriplegics, in which the upper limb was also involved, was 50%. This is the world standard. 50% of them were dead by 1 year. Now, bringing this and reducing the complications have reduced them almost 1/3 in paraplegics and 1/2 in quadriplegics. The suicide rate, which was 4.2% because of massive depression, was reduced to 0.5%. Severe depression, which was in 21.8%, was reduced to 9.4%. And this is not just depression for the patient, it's a depression for the family also. And many of these people, when left to lie in their homes without any medical treatment, they went through a lot of pressure sore. and this is the sore and wound that they get, this was reduced from 25.3% to 4.8%. Respiratory tract infection and urinary tract infection, which was the secondary killers in these people, was also reduced by more than 1/3 in paraplegics and 1/2 in quadriplegics. Now, this is important. Rate of patients returning to work, and this is the important thing. They all returned to work. Now, you can see here, this is a patient who was a young person who was involved in this accident and who had a rehabilitation. And you can see this person who would have had pressure sores and had a chance of 30% mortality at 1 year is being completely rehabilitated. And then we also integrated him and got a auto rickshaw for him through the Rotary Club. And you can see from a person who was completely dependent, he has now become an auto driver. And he is also actually the secretary of the Auto Drivers Association over there. Mr. Dinesh, he was a construction worker. For 1 year, he was lying in bed. As a result, his wife also was not able to go for work. And this you can see on his rapid rehabilitation. I'm just fast forwarding. He became completely independent. And you can see that we also allowed him to get a small petty shop. And you can see there that this was opened by the local church. And he is now a breadwinner of the family. More importantly, his wife is back to work. In people who have low, this is a stunt bike rider who had a massive accident. And he had a complete paraplegia over there. You can see the whole spinal cord is cut into two. He was immediately operated, and luckily because it was at the lower level and operated immediately and the spinal cord was decompressed, from a life of complete disaster, you can see he is partially recovering. And by 3 months, he had recovered enough to go on the steps, and this is back on him, and he is now back to stunt riding actually. You can see still he is not wearing a helmet, but that is the problem of India. So this novel method has given a end-to-end care and life without disability. Why is it unique? Because it addressed a group of people forgotten and left to die, and novel because it gave a single center, made it available and affordable, and produced disruptive results. Thank you very much for this.
Thank you, Dr. Rajshekharan. Now we move on to a question and answer session. So audience, if you have any questions, please direct it with the name of the organization whom you wish to ask the question to, and hand it over to my colleague, Ashita.
I think a good presentation by each one of them. It was very interesting and very also something new to learn as a panel member. The first question is to Amrita Institute. I think what you did you scan some available patents which can give you some inputs for this ASP program? I'm sure there will be patents which will be there in terms of this antibiotics.
A standard process that the World Health Organization advises. So we collaborated with them and implemented that in our hospital. Along with that, what we also did, along with ensuring that the hospital, the patients and the hospital benefits, we also made sure that the benefit of the program involves the whole state of Kerala, plus nationally as well as internationally. As far as future is concerned, again, we wanted to have the benefits of this program to the future generations, which is why we lobbied to involve the antibiotic stewardship program within the medical curriculum. As far as patents is concerned, because we did not actually involve or invent any new process, I don't think there was a question of patenting the program that we have started.
No, my question was, did such program, was there any patented elsewhere in the world, and you could take inputs from there, and which could have incorporated in this program?
It is mainly based by the guidelines by the Infectious Disease Society of America and the Society for Healthcare and Epidemiology America and the ICMR. There was no patents involved.
Okay.
The question asked by the audience is, what was the reaction of doctors who are competent to decide the quantity of the antibiotics and reviews by clinical people? How did you manage to get the doctors involved?
That's a very good question, because one of the problems that most people who try to start an antibiotic stewardship program face is the backlash or the resistance to change. The advantages that we had was that we had the administrative champion within the group, so they were keen to drive the change. Yes, there were apprehensions regarding the antibiotic program. The changes that we did was, one, involve the clinicians, because as he said, we involved more and more clinicians as time went by. We went to the bedside and discussed the process with the clinicians. It is not that the stewardship people were sitting in a room and advising people. They went to the clinics, spoke with the clinicians. There were one-to-one interactions, or either in person or over the phone. They were definitely filed in the notes. Plus, we gave them positive feedbacks when it was appropriate in the form of congratulatory emails, plus the hospital newsletters which appreciated the work. There was a lot of resistance to start off with, but over time, people have started involving the antibiotic stewardship team and actually calling us for further antibiotic management as well. To the extent, I would like to state an example wherein in our hospital, the neurosurgical and the urology department have stopped prescribing antibiotics apart from the perioperative surgical antibiotics. Whenever there's a patient who requires antibiotic, they get straight referred to the antibiotic stewardship team, which includes the infectious diseases team. So that is the extent of change that we are able to bring forth in our institute. Thank you.
So to Baby Memorial Hospital, there are two queries, I'll say it together. Number one, it says that GPS does not work inside the buildings, and how did you overcome this challenge? And number two is, have you implemented real-time tracking mechanism to ambulances as well with this?
Yes. The GPS doesn't work in a multi-story building. So instead of using GPS for tracking, we use a wireless access point. So it's in a multi-story building. We deployed almost 150 wireless access points. With reference to the wireless access points, based on the signal strength, we do the triangulation principle, and that is how you are able to use that one. So that is how, in a multi-story building, we cannot. That is called internal positioning. Typically, using GPS is global positioning. This is using the satellite. This is IPS, internal positioning. So that is in terms of the technology. And on the second point, yeah, we use the GPS technology in ambulance. We have an app for the patients. There we have an emergency button being given. So from an ambulance location, a patient wanted to give a call, just press it with the GPS quadrant. It comes to our emergency room, and we are able to go and locate. And we have used the GPS as well as IPS technology.
This question is to Ruby Hall Clinic. I think one thing which, when we saw through the presentation, was that I think there was some changes in terms of mindset. We wanted to understand what was the mindset change which has happened in terms of asking that your team to ensure more compliance.
Yeah.
Because it was more the checklist, you said that we did this, then the other part of the labels and everything. So I think it was more a mindset change. Approach was more. So
yes.
Can you elaborate on
now,
that?
Madam Panikar would more connect with me because she is from the medical fraternity, but transfusion medicine has really evolved. You know, right from the time when you used to think कि एक blood, whole blood collect करो और एक मतलब हर रोग की एक ही दवा है, that is whole blood. So we have moved ahead, and transfusion medicine as a specialty has really evolved. But what happens is that in many hospitals, especially the smaller ones, it is the mindset that blood transfusion is a purview of the staff nurse. So the doctor orders blood and sister transfuses it. But the blood transfusion is such a risk, we always say it is a double-edged sword. So if done the correct way, it will definitely save the life of the patient, because as I said, we have not been able to produce blood in any factory or laboratory. It has to come from a human source. Nonetheless, more than 250 diseases also can be given through blood transfusion. Like I would clarify a little more, that you give a blood bag of A to a B patient, there will be definite mortality. But if the blood of A is given to A, but not in the stipulated period of time, or if somebody injects anything into the bag, or if we have this three-way procedure where multiple fluids or medicines can be given to the patient at the same time. So if anything is given with blood, hypertonic or hypotonic solutions, it can actually kill the patient. I cannot sum up the money involved, but you can imagine the trauma to the patient, the amount of days that are increased, the hospital stay. So even if, let us say, in an extreme case, the patient is not dead, but the morbidity involved is a lot. So we had to change the mindset of the doctors that yes, as doctors, you definitely make the plan of transfusion, which component in what quantity and when to transfuse, but you as well involve yourself in the process of transfusion, because only writing the prescription doesn't help. Only if the product is transfused the way it is supposed to be, it will see the effect in the patient. So definitely this mindset had to be changed. But you know, many a times we don't go to the people and tell them why it is important. Just saying do 1, 2, 3, 4, 5 will not get you compliance. Through lectures and trainings, we have to tell them this is what you have to do. If you don't do this, this is what will happen. And that is why involving the doctors and the sisters, quarterly trainings of the existing doctors in the form of continuous medical trainings, that CMEs as we call it, and CNEs for the nurses. And as soon as we have a new member entering our Ruby All Parivar, the induction program is there. So as I said in my presentation, that blood transfusion protocols are a part of every induction program for new doctors and sisters. I am also happy to add that we are not happy with only implementing it in my center, but I am a member of Hemovigilance Program of India. So it looks after the donor vigil and the patient vigil. So last month we had a meeting in Delhi, and I shared my presentation with them, and they were so happy with it that now I am happy to share with you that some of these practices will be introduced for our country. Many blood banks will benefit from it, and many patients will benefit from it. So mindset, yes, that's the first it has to change. Mindset of the management, mindset of the blood bank staff, mindset of the ward doctor, mindset of the consultant, mindset of the staff nurse, because the patient, poor fellow, is not aware of the procedures. So it's the mindset of the clinical side that needs to change.
Okay, thank you. I think this question is for Ganga Medical Nurse Center. I think I understand this was a 2-month therapy which a patient undergoes. After that, do you continue to keep engaged with the patient?
Oh yes, yeah.
Yeah.
So once the patient goes back, as you had seen in the patient who had been given an auto rickshaw, that is where we engaged with the local charitable organizations like the Rotary Club and got him an auto. And the person who had established a petty shop, now that was also arranged by our center by getting him a small loan. So we have our social workers who visit them periodically just to make sure, and even before they get discharged, our social workers go to their home and make sure that the home, there has to be always a small modifications done at home so that the wheelchairs move and they can do that. Just small modifications will make major differences. So we do that and also have a periodic visit to them all the time. And at every period of time, you can take them one step higher. A person who has been with a petty shop, you can get him to do better with some help after some time. So we do that on a continuous basis.
Just wanted to ask you about that. You reduced your mortality almost 50% in 1 year. So, I mean, what was the root cause, or what was actually...
So why the mortality comes is very important, because the mortality comes through complications. So there are 3 big complications which kill these patients. Number 1 is the pressure sore. So the pressure sore is because they are lying down, they don't know how to look after themselves, the family members do not know how to look after a paralyzed patient. And once you get a deep pressure sore, it's such a source of major infection that the infection takes them to septicemia and then it kills them. The second thing is they have lost their bladder control, and so they are not able to pass urine. So they have to be on catheters, or they have to be on self-intermittent catheterizations. Now if the hygienic aseptic method is not taught to them and it is not supervised, these patients get repeated urinary tract infection, which again kills them. The third is because most of them have very poor lung complaints, because most of the time the respiratory muscles are also paralyzed. Some of them are breathing only through the diaphragm. And so respiratory tract infection, one small cough or cold can kill them. So if you prevent complications, then the complications are the one that kills them. So by preventing complications, you increase their longevity.
So last query to GVK, sir. So how do you select, what are the selection criteria to come up with the emergency centers, And have you all also tied up with other tertiary care hospitals, which is, say, closest to the ECCs that you all have put up?
Yeah, emergency care centers are identified as those who have prolonged transport time and they go into complications. Suppose Chennai is the metro city, and around the Chennai there are 3 districts which is not medically developed. Everybody would want to invest in Chennai, so surrounded by Chennai district there is no multi-specialty hospital, so that the transportation time from one particular place to come all the way to this tertiary care center, if it is prolonged and the patient becomes sick, there is a complication occurs. So that these particular locations are identified, and we started with one center in Chennai, that's the suburb of Chennai. Now Tamil Nadu government has increased such centers 20 places across the state. So across the India, the problem is same, because specialty hospitals are in urban area, in the rural area it is not available. So this complication arises during transport can be stabilized at such centers.
Okay, thank you. One question to Baby Memorial. I think during this entire process, did you do a cross-industry benchmarking, because it was more increasing, enhancing the productivity? And the second question is, what was patient satisfaction index, basically? You said that it has increased, but can you have some data for that?
There was an increase of 5% increase in the patient satisfactions. Both for the IP and OP patients, we do a customer satisfaction index. So there was an increase of 5% in the last 6 months. And in terms of the productivity, we had 40 team member dedicated for these services. Now we were able to bring down to 32. And maybe further we will be able to do with predictive analytics, and we will be able to forecast what is going to be the workload. Because in a hospital, very heterogeneous in nature, because during the days of the week it changes, and then seasons of the year it changes. So if we can introduce a predictive analytics based on the historical data, we can do that one, we will be able to optimally utilize them.
No, my question was more, did you do a cross-industry benchmarking? How to increase this productivity, transportation, because there are other options also, other industries. Did you look into other industries?
No, I didn't look at other industries.
Okay, thank you. I think, thanks a lot.
Thank you to all the participating organizations. You can take your seat in the audience. We have the results. May I invite our panel of judges to please come on the dais to present the trophies. In the service category, the winner is Aditya Birla Sun Life Insurance Company Limited. Congratulations, winners. Healthcare category gave a tough time to our panelists, and that is why we have a tie between two organizations. First, the winner is Amrita Institute of Medical Science and Research Center, Kochi. And we have the second winner, Ganga Medical Center and Hospitals, Coimbatore. So that's Amrita Hospital. The team from Ganga Medical Center and Hospitals, Coimbatore. Judges, we have certificates for all the participants. So may I invite participants from the service category, Aditya Birla Sun Life Insurance, Ms. Arpita Sen Gupta, AVP Head Quality and Business Excellence, and Mr. Akhil Jeswani, AVP Revenue Assurance. Audience, a big round of applause. From Marathon Group, Mr. Surya Prakash Yadav, Assistant Manager. Mr. Vishal Dahale, National Manager Select Program, Aditya Birla Capital Limited, Mumbai. Mr. Raman Kumar Jha and Mr. Preetham Walunj from HDFC Life Insurance Company, Mumbai. In the healthcare category, Dr. Zubair Mohammed, Consultant, Amrita Institute of Medical Science and Research Center, Kochi. Dr. Snehal Majumdar, Director, Blood Bank from Ruby Health Hall Clinic, Pune. Mr. Saji Matthew, COO, Baby Memorial Hospital, Kozhikode. Mr. Vimal Megavarnan, Manager, GVK Emergency Management and Research Institute, Secunderabad. Dr. S. Rajshekharan, Director, Ganga Medical Center and Hospitals, Coimbatore. As a token of our appreciation, we would like to give mementos to our panel of judges. May I invite Mr. Suresh Lula, co-chairman of the Quality Improvement and Technology Committee and one of our founders of the IMC RBNQA award process, to please give the mementos. Mr. Shailesh Godekar, Head Corporate Quality Assurance, Marico Limited. Dr. Mini Panikar, Founder, Sabhav. Mr. K.A. Konjumon, General Manager, Product Dispatches, Bharat Petroleum Corporation Limited. C.A. Jagdish Shenoy, Senior Vice President, Edelweiss Limited. Thank you, everybody. Now we break for lunch.